Thank you very much, David, and welcome everyone. Uh, I'm going to try and this is a very complex issue, and so this will be very much a skimming through some of the issues that it raises. But one of the things I wanted to say was, first of all, that uh, in the last few uh, years, I studied for a master's in the University of Glasgow in end of life studies. And one of the modules that we did was on assisted dying, and we spent a whole module on that. And I have to admit, before we started that I was a little anxious that 12 weeks study on what seemed like a very narrow issue felt like it was too much. Well, actually, having done it, it was, if anything, we could have done with more time. It's a very complex issue, and it was a very rewarding and thought-provoking course. And this is a complex issue, and it's not a binary issue. I think my thinking was that either countries do allow this or they don't, and you're either for it or against. And actually, it's much more complex, much more nuanced, much more subtle than that. So what I'm going to try and do is give you a sense of some of the issues and where the British parliaments that are considering this sit within a world context, and then there'll be a chance to have some questions afterwards. So I'm going to share my screen and do a wee PowerPoint presentation. Is that okay? Can you see that? Yeah. Yeah, good. Okay. So what I want to do today, I'm just going to run through, this is my sort of roadmap. I want to talk about some definitions. I want to look at the world and where assisted dying is legal, which jurisdictions it's legal. I want to drill down onto two places which I think might illuminate how it actually works in practice, namely Oregon and the Netherlands, and look at eligibility and administration. And then a little bit of a detour to Switzerland, but then that will allow me to look at the legislation that is currently being considered by four parliaments in the sort of British countries and where they sit in that world picture. I want to then just look at a few issues. Well, there's so much that we could talk about, but I'm going to try and look at just a few issues and then try to bring the conversation round to the impact that this might have on the work of, well, I'm a celebrant, but on the work of celebrants, funeral directors, people working in hospice, people working in palliative care, people working as doulas, people working in grief, and see what impact this might have. And in order to illustrate that, I'm going to just share a little bit of research from Canada from one of my colleagues. And if we've got time, play a little short video of a living wake also from Canada. So that's what I plan to do. And I thought I'd start by just saying what my definitions and what I'm going to be talking about, or the terms I'm going to be using. I'm going to use the term assisted dying because I feel that's the most all-encompassing term. And the Nuffield Council on Bioethics defines that as an umbrella term for a range of situations involving healthcare professionals in providing lethal drugs intended to end a patient's life at their voluntary request, subject to a set of conditions. And it encompasses two different methods of administration, both self-administration, so the person gets a prescription and takes the substance themselves. That's often called assisted suicide, and also clinician administration of the lethal drug, which is sometimes referred to as voluntary euthanasia. I mean, assisted dying, I could assist somebody to die by shooting them, but what we're talking about here is a legal framework, okay? And it's a legal framework which involves healthcare professionals. It needs to involve clear and settled intention on the part of the person requesting it. They obviously have to give informed consent. They have to have mental capacity, and there have to be guidelines and safeguards in place. So all of that is encompassed by this definition that I'm going to be using today of assisted dying. These other terms, mercy killing, I mean, that if I have a sort of running joke with my best friend that as we grow older, we say to each other, you know, if you see me doing this, or if I start doing this, take me out and shoot me. Well, I mean, it's a joke, but the point is that if I did do that with my friend, that would not be assisted dying. That would be murder. That would be homicide. So mercy killing includes a lot of things that are completely out with the scope of this. The words euthanasia and assisted suicide, I think, carry with them certain connotations, but also in terms of discussing this issue, as I sort of alluded to, they tend to mean slightly different, slightly different things. So the assisted dying is a more neutral term, and it's a more all-encompassing term. There are some other terms there in green. That's just because certain jurisdictions, certain countries have their own terminology for these, and you will hear these terms, particularly Canada, where they talk about MAID, M-A-I-D, medical assistance in dying. And people have started to talk about a MAID death or someone requesting MAID. And the last thing I wanted to say on that was I'm just going to leave this with you. I'm not going to comment on it, but the word euthanasia, which often has rather dark connotations, in the Greek roots of the word simply mean a good death. This slide will be a bit, I think, a bit crowded for you to see in detail. But what it is a world map prepared by the Nuffield Trust of the places, the jurisdictions, the countries where assisted dying is currently legal. And a couple of things to take away from this. First of all, there are a lot of places, and it's about 300 million people live in these places. The second is why I keep saying jurisdictions rather than countries, because in fact, in some countries like the United States and Australia, this is determined at state level. And that's of relevance to us here, because although we're not a federal country, we do have different parliaments. And so it's possible for, well, in the United States, for example, Oregon, it is legal, and over the border in Idaho, it's not legal. A situation that could arise in Britain. Don't worry too much about the colors. I will come back to that in a second. So I want to drill down into two of these places because I think that will illuminate the different sorts of models of how this works currently. And I'm going to look at Oregon in the States and the Netherlands. Oregon has had a law called Death with Dignity since 1997, and the Netherlands since 2002. And I think that's rather an important point in itself, because we often talk about evidence-based decisions, evidence-based medicine. And what that tells us is that there are places in the world that have a lot of experience of this, have a lot of data that we can refer to. In Oregon, the two things that I want to look at in terms of this, I mean, there's so much that we could look at, but we'd spend all morning just looking at Oregon. But what I wanted to tease out were the eligibility criteria and how this is administered. And when I say administered, I'm talking about clinical administration rather than the paperwork, though it's important to note that in this topic, paperwork is very important. But I'm going to focus on clinical administration and eligibility. And in Oregon, people are eligible if they have a terminal illness, a terminal disease. And they define that as meaning an incurable and irreversible disease that has been medically confirmed and will, within reasonable judgment, produce death within 6 months. So it's a diagnosis and a prognosis, and it's a terminal disease-based eligibility. In terms of administration in Oregon, there's no, it's not a euthanasia. No one would administer this drug to you. You simply get a prescription, or you're provided with the drugs, but it's up to you to take these drugs yourself. So it's a self-administration route. The Netherlands also does allow self-administration, but they also have voluntary euthanasia, where a medical professional will administer the procedure, the substance. So that's one difference with Oregon. But the more fundamental difference, and I think it's a really, really important, almost philosophical difference, is that in the Netherlands, it's not based, eligibility is not simply based on terminal illness, it's based on unbearable suffering. So they define it as unbearable suffering with no prospect of improvement, and where that has a medical dimension. And they go on to say, and this is very important, and this is very different from Oregon, that this is the case with somatic diseases, meaning diseases of the body, physical diseases, but also psychiatric disorders, dementia, geriatric syndromes. It doesn't, however, allow someone who merely feels that they have finished with life, or that they deem their life to be completed. That would not fall within the eligibility in the Netherlands. But I think you can see there's there are these two very different ways of determining whether someone is eligible for this procedure. And if we just come back to that map, now the colors begin to come clear, because the green dots are those places in the world where there's basically an Oregon style model where it's legal on the basis of terminal diagnosis, and that is most of the states in the USA, the states of Australia and New Zealand. And the blue dots are where the legality is on the basis of intolerable suffering, more like the Netherlands, and it's the European countries and Canada. The orange, don't worry too much about the orange. That's where there's a sort of constitutional decriminalization or other anomalous situations. Okay, so that gives us a sort of basis in which to fit what's happening in Britain into a world picture. But before I turn to Britain, just a quick detour to Switzerland. Again, Switzerland has had this in its statute books for a long time, since the 1940s, and it's rather a different model. And they use, I guess you could call them civic societies. So Dignitas, which you've probably heard of, Dignitas is one of those societies. People join Dignitas, and Dignitas can facilitate the procedure. But the important thing that I wanted to say about Switzerland was that you do not have to be Swiss. You don't have to be resident in Switzerland. And that's a very unusual situation. Most jurisdictions in their legislation, they either specify, for example, in the Isle of Man, you need to have been a resident of the Isle of Man for, I think, 5 years. So they either specify it, or in the case of the Netherlands, it's not actually explicitly stated that you have to be a Dutch citizen, but the procedures imply that it would be extremely difficult if you weren't. So Switzerland's a bit of an outlier in that. And what that means, of course, is that even now, as British people, we do have access, in a sense, to assisted dying. It's just that we have to go to Switzerland for that. And obviously, physically, that may be a problem if someone is very ill. And it's also very expensive. So there are barriers to this. But around, I think about one person a week, that is a sort of rate of one person a week from the United Kingdom is going to Switzerland right now. So there are 4 separate parliaments that are looking at this, or have looked at this, in Britain and the Crown dependencies. And I put them in roughly in order of where they are in their parliamentary progress. So the Tynwald, the Isle of Man, has already passed this, but it hasn't actually come into effect yet. I think it would probably, because this is a complex thing to enact, it probably won't take place until 2026 or 2027. I think Jersey is not far behind that. Both of those parliaments have approved this. And again, there'll be a delay before it actually becomes law comes into effect in Jersey. Scotland and England and Wales are an earlier stage. And it's important to note that although I will talk about the legislation for both of those countries, it's important to note that it's quite likely to be amended. So what I say may change. I don't think the fundamental model will change, but there may be changes in the detail. I'm just going to rattle through these. I'm not going to go into great detail. Obviously, you can, if you really want to, you can download all this legislation if you want to read it. But the important thing is, from my perspective, in putting this into a context, is that the Isle of Man legislation is based it's very similar in its basis to the Oregon model. In other words, it's the eligibility is terminal illness. The prognosis is 12 months, not 6 months, but it is a terminal illness model, and the administration is also similar to Oregon in that it's a self-administration, although a health professional would be in attendance. Jersey is very similar in terms of eligibility, slight difference in prognosis, but the Jersey legislation states that it can be the drug can be administered by a health professional. So in that regard, it's slightly more like the Netherlands model. But both of those, if we were to go back to that map, both of those places would be green dots. The Scottish legislation is also eligibility also on the basis of terminal illness, although strangely there isn't a prognosis timing. I have a feeling that's one of the things that might be amended in the Scottish as the Scottish legislation goes through Parliament. And administration like Oregon and like the Isle of Man is a self-administered, although a health professional would be in attendance. England and Wales is very similar to this. The Scottish Parliament has voted at stage 1, and it obviously passed that stage. Otherwise, the bill would that would have been the end of the process, and it would have that would have been the end of this bill. So it has gone forward. That doesn't, of course, guarantee that it will become law, but it has gone forward, and it's now at a stage where it will be amended and considered by committee. I thought it was quite interesting. I don't know if you'll be able to read the bottom part, but these are my MSPs, members of the Scottish Parliament. If you're not familiar with it, Scotland has a proportional representation system. So I actually have 8 MSPs, 1 constituency and 7 sort of regional list. And I wrote to them all to find out what their views were. And this was before the vote. And just one interesting thing came out of it because they all replied. And Shona Robison, for example, of the Scottish National Party, she wrote back to say she would, very politician answer. She would look at the legislation, she would listen to the debate, she would consider the arguments, and then she'd make up her mind. But I got the feeling that she was rather against this. And in the past, this is actually, I think, the 3rd time this has come before the Scottish Parliament, she has voted against. So I thought that she was probably going to vote against. She voted for. Tess White, on the other hand, a Tory, was of all of the people who responded, by far the most effusive in her support in principle of assisted dying. And she actually shared some quite personal testimony of someone that she had watched in the last stage of their life, and she voted against. So I think I just put that in because sometimes, we have probably quite rightly a very low opinion of politicians, but sometimes when an issue is taken out with the party political divide, parliamentarians do listen to argument and do think about these things. And in this case, these 2 people started with one position and they kind of changed their position. I just think that's quite an interesting observation about the parliamentary process. I've talked about where England stands. So England and Scotland, both these green dots, if you remember the world map. And that's just a little thing on the UK Parliament's procedure. So it's at the report stage, I think, is what it's at now. But in England, of course, it would have to go through the House of Lords. So there's an extra stage, I think. The breakdown by party shows, again, this is not really a party issue. There's red, blue, and yellow on both sides of the divide. That puts what's happening in Britain, or has already happened in a couple of the crown dependencies, into some sort of world context about what this legislation might look like in practice. And I wanted to touch on just a few issues. Obviously, this is just the very, very superficial touching on these things, but I want to try and pull a thread through some of these things that are are raised by this legislation. The first is palliative care, and I put that in because I know that one of the strongest voices, north and south of the border, against the legislation came from professionals in the palliative care in palliative care. And I think that's because people fear that palliative care isn't afforded the resources that it needs, and that if governments believe that there's a sort of easy way out and that people will end their life as a kind of, to put it bluntly, cheap way of sidestepping palliative care, then they will not put the resources into palliative care. I think it's quite a compelling and strong argument, but it's worth looking at. Remember, I said that Oregon has been doing this for a long time, and so we do have data. And it's interesting that Oregon is considered to have some of the best palliative care in the USA. Also, and I think this is really interesting, in the United States and also in Canada, a large proportion of the patients who request assisted death are already receiving palliative care, but they have still decided they want to end their life. And this takes me into the second thing, which is pain. And I don't know if you'll be able to read the graph, but what that is statistics from Canada. And it's about how people report the nature of the suffering that they're enduring. And it's true that inadequate pain control is there. It's quite far down, and it's 54 to 58%. So percentages go up as you go down the axis. But there are things that seem to be more important to people, such as loss of dignity, loss of ability to perform activities of daily living, loss of ability to engage in meaningful activities, and other things which are perhaps not as high, but are still there, like isolation, emotional distress, existential suffering. And it makes me think about the work of Cicely Saunders, the pioneer of one of the pioneers of the hospice movement in England, who talked about total pain. And what she meant by that was that pain wasn't simply a physical thing, it was also it was mental anguish, it was social isolation, it was religious or spiritual or existential angst. And it's all of those things that are relevant, and not just the control of physical pain. And one of those things in the Canadian statistics there, which is a very concerning thing in a way, is perceived burden on family, friends, or caregivers. Nearly 50% of people mention that. Because, of course, although the eligibility criteria state that you have to give your consent and it has to come from you, and there's no sense of coercion into this, there are subtle pressures within us that we do something, even though it's not maybe what we want to do, because we want to remove burden on our family and friends. And this is something I think that we have to be aware of. And it brings me to the next point on my list, which is disability. And that's because another of the strongest voices speaking out against the legislation has come from activists and advocates of the disabled communities. And again, I can quite see why that would be the case. To be honest, I've read the legislation quite carefully, and I don't really see in terms of the letter of the law, terms of the letter of the law, I don't see that those fears are justified. But to me, what this does is it sheds a light on something more profound, which is how disability is actually perceived in this country in the 21st century. And whether or not the legislation is approved or not, that perception of disability is that it is a burden. And I think that's not a flattering light to be shed on our society. The last point was the prolonging of life. Of course, we do, my grandmother died when she was 71, and that was considered a good age at that time. I'm now 65, so I'm hurtling towards that. And my mother, her daughter, is 90. So we're used to the idea that we're living much longer. And also medical science helps prolong life in all kinds of situations. And I just wanted to point out that although we're talking about people choosing to die, to have their death assisted, the actual numbers will always be quite small. Even in a more eligibility permissive place like Canada or the Netherlands, it's still quite low. So that many of the issues that spring from this prolonging of life, the things that we associate with an aging population, are not really going to be affected by assisted dying, whether it comes in or not. However, it will, if it does come in, it will have implications, and it will have implications for the work of people like myself, celebrants, funeral directors, um, people working in hospice, grief professionals. And I thought it might be useful just to look at some research that a colleague of mine, Kelly Oberly, did. She studied with me on the University of Glasgow course. She is Canadian. She lives in Vancouver. And what she did was to interview the families of people who had died through MAID. Remember, MAID is MAID, is medical assistance in dying, which is the term that's used in Canada. She found that there were real challenges, stigma, social disapproval, issues around disenfranchised grief, isolation. They talked about a series of lasts, last meal, last chat, last goodbye, which can complicate bereavement, and even rejection by religious organizations, not being able to have a funeral in the way that they had wanted. Set against that, though, were some very positive experiences. And I got the feeling that in many cases, people found these experiences positive almost in spite of themselves, because often it is the family that are less keen on their person dying in this way than the person themselves. Families are often the resist this. So it was almost a sense of surprise, but there were positive experiences. Kelly talks about a sense of intentionality of being, once you know when your death is going to take place, there are things you can organize and do in advance. There are opportunities for meaning making. And even, and you'll recall I mentioned that the word euthanasia means a good death. And it was interesting that one of the things that people talked about was that for their person, this had been a good death. Even using the word, and it's a strange word perhaps to use in this context, but even using the word beautiful. So I think that these things will have, if this legislation comes in Scotland or England or both, it will have an impact, even though the numbers might be quite small, on how people see ceremony and the things that happen around that end of life period and how that impacts on our professions. I think what I'm going to do now, if we've got time, is I'm going to simply show you a short video. This is of a gentleman who organized a wake, his own wake. This gentleman is Canadian, and he chose to have MAID and to die through that. And he organized a wake. It's quite short. It's quite emotional. I'm not doing it to advocate either for or against. You may think it's a horrible thing to do. You may think it's a wonderful and beautiful thing to do. I'm not going to comment on that. It is quite moving, so it has a sort of medium to high handkerchief rating, if I may put it that way.
Today is the last day of my life. Hi, Ben. How are you? Good to see you. Oh, cheek to cheek.
One tradition of yours that we will have to keep alive is the winter solstice ceremony.
Oh, good. Yeah.
Do you remember this?
Oh, do I ever? Oh, yes.
I didn't get the dress up memo, I'm sorry.
Well, Here I am in my pajamas, so I can hardly complain. Do I look like a contented cow? A contented Greek fisherman?
We're befriending death. We're holding it. We're witnessing it. We're taking it back into our own hands.
You're going to be the star here.
So this is the very significant Swiss chalet meal.
No, this is the chicken, but are ribs a special thing for you as well?
Well, do you think I'm only going to have one portion?
We're going to start with
He's going
one.
to have many portions.
I was just not wanting the moment to go by without taking full opportunity of my privilege as dying host to introduce some of you to each other who don't know each other.
So I'm Kathy, and I came to know John through my working life. And what I can say about John is in a short time, you fall madly in love.
You're always so welcoming and kind, and that's what I'm going to take with me.
I admire your wisdom and your courage and strength, and we'll be seeing you around.
I guarantee it. I haunt.
You've talked a lot about some of John's abilities. I want to talk about one more. And that is he has an innate ability to piss you off. Anyway, John, I'm not saying goodbye. I'll see you down the road somewhere.
The end of the road is not far beyond. For each of us.
That's right.
Give me back my...
I rest my case.
And to all of us who've come together, you're seeing me get sad. It would never happen without some sadness. Do I look like the Queen? Do I look like the King?